Here to this Medicine Grand Rounds. I particularly want to welcome our nurses, MAs, and coordinators from the Hepatology section for their loyalty and devotion. So it's my pleasure to introduce our speaker today, who is Parth Shah. So Parth was an undergrad and medical student at SLU, did his medical residency at Cedars-Sinai in LA, and then we were delighted to recruit him here for GI fellowship. So one of my fondest memories of Parth is rounding with him at 9 o'clock on a July evening in his first year and getting through 21 consults. That was the black cloud that has followed Parth through fellowship. So and we billed for those consults. Parth is a very humanistic, empathic person, decided that he was interested in hepatology and has developed a niche interest in palliative care. So what he's going to talk about today is a really remarkable collaboration that was made possible by collaborations with Patrick White in the Division of Palliative Care. And Parth is going to talk to us about a new program to take care of patients with end-stage liver disease, palliative hepatology. So please join me in welcoming Parth Shah.
Thank you, Dr. Davidson. Very happy to be here to be talking about palliative hepatology. And so to begin with, no disclosures. I'm going to start with this slide here. So partially it's an excuse to show you pictures of my dog, but actually he's a reminder of kind of how I got interested in palliative hepatology. And it did start in residency at Cedars-Sinai. I remember rounding on the inpatient consult service. We would see patients, our list was 30, 40 patients long, and we would see these patients with end-stage liver disease, and there was so much weight that was put on whether or not they're a transplant candidate. Regardless of what that decision was, whether they were a candidate or not, it felt like once we made that decision, we kind of just backed out of that room, kind of wiped our hands clean, went on to the next patient. And it felt like there was something missing there, and we definitely got that feedback. Patients were definitely upset with us. Providers in the inpatient side were definitely like, well, what's next? You're just kind of left us with this patient who still has a lot of different symptoms, a lot of different questions about what to do next, what's next for their health, what can they expect. So I started getting that feedback, and I started realizing, well, there's something missing here. And then as time went on, I started getting feedback from the patients that they weren't really happy with seeing us, but they really liked a specific group of people in the hospital. And at Cedars, they had this volunteer group that would come around with pet therapy. They would bring like mini horses, donkeys, dogs, puppies, cats, and obviously, petting these dogs, the patients knew their MELD scores weren't going to improve, their ascites wasn't going to disappear, but they just felt a lot better. And it made me realize that a lot of these patients with end-stage liver disease that really benefited from this pet therapy are people who had pets at home. They felt like they were missing something, that there's a huge component of their comfort, the huge component of their life at home that we weren't really integrating. Obviously, we can't have everyone bring in their dogs and pets into the hospital, but it made me realize that I think in order to provide appropriate care to these patients and effective care, I think we need to start incorporating some of these aspects of life outside of the hospital into their care. Whether this improves adherence or just improves their quality of life and makes them happier, I don't know if it really matters. I think in the end of the day, sure, when the patient walks in, our job is not to ask them about if they have pets or not or what their favorite NFL team is, but it's more so to obviously get them feeling better, get them out of the hospital as soon as possible. And this could be as simple as realizing that, a patient can't afford $2,000 of rifaximin a month because they only bring in $1,000. But we shouldn't keep on forcing it down their throat then and make them feel like they need to, come up with all the means to pay for it. It could also be as simple as I have a patient who this football season said, I am not going to take diuretics or lactulose on Sunday because I'm not going to miss a touchdown on NFL Red Zone. We can work with that, and I think it's important, obviously. We just have to figure out ways to kind of work around that and figure out what is truly important to these patients. And so what I want to talk about are these 4 objectives. I really want to start off with defining palliative care specifically as it pertains to patients with chronic liver disease. And then I want to discuss some of these screening tools that I really like to try to elicit these symptoms, try to figure out what are these unmet needs. And then, of course, we're going to kind of transition into a brief summary of how we can intervene and improve the quality of life for these patients. And at the very end, I'm going to be talking about the program that Dr. Davidson was alluding to. That's a very brand new inpatient collaboration with palliative care, in which we provide early palliative care to these patients with end-stage liver disease. And so that's what the beauty of palliative care is. We obviously all know what it is, and it's amazing because it's multidisciplinary care. There's different people with different expertise that really treat a patient and look at these different needs of the patient. So it could be physical, could be spiritual, could be psychosocial as well. And it's really based on these fundamental principles of focusing on symptoms and pain, depression and anxiety, and of course, making sure that the caregivers are also included as well. And of course, this can be given at any point in the disease stage. So patients with end-stage liver disease, we can provide palliative care before transplant, while they're on the wait list, even after transplant, because patients are still allowed to have symptoms, they're still allowed to have quality of life as well. And I really like this slide because it shows that everyone in this room can actually provide primary palliative care. There's a difference between primary palliative care and specialty primary care. Primary palliative care can be any provider that just has an easy, open-ended discussion about patients' symptoms, how we can help them. Sure, we can talk about diagnosis, prognosis, and really what matters to the patient, because in the end of the day, coming up with that treatment plan and focusing on what's truly important to the patient, that's really what's important. But of course, we still need our palliative care colleagues, and we still need to bring them on board, especially in some of these very, very difficult cases. So I'm showing this not because I think every single time we see a patient, we need to go through steps 1 through 13, but there are some common themes here. And this is adopted from the American Society of Clinical Oncology. And really what the whole idea is that we should be having these conversations with patients, open communication. We should be figuring out what do they know, and more importantly, what do they not know. And we try to bridge those gaps, because if patients don't know what to expect, if they don't know what's a symptom of chronic liver disease, how do they know to tell a provider? How do they know to get that treated? And based on that, and based on using tools to try to elicit some of these symptoms and some of these unmet needs, then we can truly, truly figure out what the patient needs as well. And during this process, figuring out what's important to the patient is also obviously critical to providing them appropriate treatment. So if we have an 80-year-old who has a bunch of cardiac disease, we shouldn't really be talking to them about transplant, because we know they're not going to be a transplant candidate. So why dangle that hope in front of them just to take it away from them when we already know that answer to begin with? So why does it matter for these patients? So the truth is that often cirrhosis is very much a progressive disease. That means it doesn't get better with time. Cirrhosis will be there. And of course, some people stay compensated for the rest of their life, but a majority just progress. They have more and more symptoms over time. They have more and more admissions. They have more infections. They have more financial burdens. And of course, the caregivers also start burning out. Only 11% of patients end up getting palliative care or hospice referrals, and it's often way too late. We've all seen it here where patients come from 3-4 hours away. They come to us intubated on 2 pressors. Well, our only option at that point is go to comfort care at that point. We're not really able to have any of these discussions. Whereas if we were to have them earlier, maybe we can avoid that. Maybe we can avoid coding someone at 2 in the morning who's 80 years old and we knew was never going to actually be a transplant candidate. So what ends up happening is these patients end up getting a lot more resource-intensive and invasive end-of-life care. And this is very much avoidable. And what some of the studies have shown is that when we do integrate palliative care with treatment for our patients with cirrhosis, we do see reduced resource use, decreased length of stay. We see decreased readmission rates as well. I mean, we've all had these patients who are in and out of the doors very, very frequently, and we're wondering, what are we doing wrong? Where are we failing them? And there's one of the most important things that I've seen is that there's an earlier consensus of care. One of the hardest things, especially when we dangle this idea of transplant as the cure for cirrhosis, is that patients hold on to that, family members hold on to that. But I think it's our job and our duty to know what's actually realistic and setting appropriate expectations as well. So this is usually what ends up happening. So you can see on the y-axis here, you have functional status, and on the x-axis, you have time. So what ends up happening is patients usually are walking around normally, and they already have compensated cirrhosis. They just don't know it. Then at some point, they have a decompensation. Maybe they become yellow, and maybe they develop ascites, or maybe some confusion. And that's when there's a shock of diagnosis at that point. there's a huge delay in illness understanding because the patients at that point are still coming to terms that this is the rest of their life. They're going to have to be on medications for the rest of their life. They're going to have symptoms for the rest of their life, and there's nothing they can really do about reversing the cirrhosis. And that's a huge shock for someone who was just presumably healthy right before this. So that delay in understanding leads to emotional distress, and all this time, the functional status is just getting worse and worse. And then, of course, caregivers are learning that there's a lot of changes, and they're watching their loved one deteriorate in front of their eyes. They have no idea what's going on, what their diagnosis is, what their prognosis is. They go to Google, they go to MD Calc, they figure out what a MELD score is. Then they go down this rabbit hole and say, well, my loved one's going to die in 30 days. And this leads to so much more distress. And of course, as time goes on and all these readmissions happen, then of course there's financial distress. And then at the very end, you can kind of see that fork in the road there. It's either liver transplant or death. But I think we all realize that the reality is not many of these patients that we see, especially inpatient that come to us, end up actually being appropriate candidates for liver transplant. So really, in the end, the only option is death. And that death is usually very prolonged, very, very painful as well. So how do we usually try to intervene? These boxes kind of show where we try to help these patients. So once they have this decompensating event, we try to help them with their illness understanding. But as they get worse and worse, as they become more frail, cachectic, we try to help them with their symptoms as well. We try to help them with coping as it comes up as well. And of course, as we gauge caregiver burnout, we try to support them as well. And at the very end, we do some advanced care planning because at that point, well, it's either transplant or death. But that's not really how it should be. In an ideal scenario, it should look more like this, where we're doing everything at once. So ideally, if we have someone with compensated cirrhosis, we should be telling them everything they need to know about their illness, what symptoms they could have, what to look out for, and also when we treat them with medications, what side effects we should look out for as well. We should try to help them with coping skills from the beginning. We should help them with their caregiver education and make sure that the caregivers feel supported. Because one of the things that we've all realized is that caregivers are extremely, extremely important in caring for these patients with end-stage liver disease. You know, how else are the patients going to know to titrate lactulose if they're already confused? We need someone there that's checking on them. How are the caregivers going to know unless we educate them on that? And so the same token goes with advanced care planning. We should be talking about their goals. We should be talking about what's appropriate treatment for them at the very beginning. So we know that if a patient says, I'm not accepting any blood products from anyone, well, they're not going to accept an organ from anyone else either. So why are we dangling transplant for them as well? And so this slide is meant to be overwhelming and busy because patients are given surveys, and this is what they respond with in terms of what they're concerned about, what they're stressed out about, and it's a lot of things. You know, there's a lot of symptoms you can kind of see in that first bullet point, but all these symptoms, they're not necessarily what you would expect from chronic liver disease. Some of these can happen because of our treatments. So when we put someone on lactulose and diuretics, there's incontinence and urgency. We often forget about that. Then there's sexual dysfunction, not only from the hormone imbalance from cirrhosis, but also from the beta blockers we like to give to everyone. Then of course we can cause muscle cramps, there's poor appetite, there's losing weight, and there's that revolving door where we say, okay, a patient is too weak to receive a liver transplant, but at the same time, they have all these symptoms. How are they gonna tolerate food? How are they gonna gain muscle mass if they're fatigued? So it really is a vicious cycle. And these patients really struggle with just having progressive decline over time. And a lot of these patients, they're their sole, caregiver. They don't have anyone else to help. They have a fixed income, and so it's very hard for them to get the care that they need. A lot of them don't know what their MELD score is. They don't know what transplant entails, and they think, okay, just get me to transplant. They don't really care what it means. They also don't know what qualifies as a good transplant candidate as well. So really, communication is important. Illness, understanding, and expectations are extremely, extremely important. So what we end up seeing is patients and their caregivers end up trying to focus on what they can control. So we get a lot of questions about, okay, what diet can my patient eat so that they can reverse this cirrhosis? And a lot of that obviously stems from a lack of understanding of what their true diagnosis is, but a lot of it is because care for their liver is often out of their hands. When patients are on the wait list, it really is a waiting game. They have no idea if and when they're going to get a liver. Same thing applied to these supplements. We have so many patients now that are spending hundreds and hundreds of dollars on supplements because they're hoping that milk thistle works. They're hoping that this new liver dose shake works, anything that it takes that they have control over. but they really don't realize how poor their health is. And this applies to even procedures that are not related to the liver. So for example, a lot of patients want to get hernia repairs, they want to get their gallbladder removed, but if they have decompensated cirrhosis, or even cirrhosis for that matter, they're at significant high risk of morbidity and mortality, and they don't realize that. And they also don't realize they have to make a lot of changes in their lives. Obviously, they're on new medications. They have to get upper endoscopies for varices. They have to get ultrasounds for hepatocellular carcinoma. And they're a lot more reliant on their caregivers as well. And that's a big change for these patients. And on the flip side, when we ask the caregivers, there's just as many concerns. And as I mentioned, caregivers are very, very important for care of these patients with end-stage liver disease, and just in general with palliative care as well. But there's so many, there's a range of emotions. The patients themselves there's a lot of mood swings, whether that's related to hepatic encephalopathy or cirrhosis in general. But these caregivers are figuring out how to be effective caregivers. And they don't see themselves as caregivers, right? I mean, all these patients, they have loved ones, and they don't see themselves as caregivers. So often they take a brunt of that caregiver burden, and they just say, you know what, I'm here to do this. This is what I'm expected to do. And they don't really care for themselves, which is very, very important. They're unable to plan for the future, and they're unable to also proceed with programs that support palliative care or hospice because they feel like they're giving up as well. So how do we do this? How do we kind of fix all of these problems? How do we address these problems? Well, obviously it's communication. It starts with communication because I think, as I'll show later during one of our pilot programs here inpatient, there is a very, 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 very huge disconnect between our providers and our patients and their family members. And in order to provide palliative care, you really do need to build trust and provide clarity as well. So providing the patient's diagnosis, their prognosis, and then figuring out what's important to them. And that's really how we're going to actually increase adherence to our treatment plan as well. I personally do like the ask, tell, ask method, especially when talking to caregivers, because figuring out what they know is very important before just giving them a bunch of information. Then after you tell them how to care for their patients, whether it's titration of lactulose, try to get them to verbalize it back to you and just confirm that they know exactly what is expected of them. I also like to write down information for patients as well, whether inpatient or outpatient, because they often do need something to refer to that they can remember. A lot of them, although MyChart is great, a lot of them don't have access to MyChart, so printing something out for them, writing something out for them is very, very helpful. And one of the other big things is setting expectations. There's a lot of symptoms that are very common in end-stage liver disease, and patients and caregivers need to know what to look for. And of course, knowing that also the treatments that we provide also have a lot of side effects, and knowing what to look for once again is very, very important. So there are a lot of tools that we can use for serious illness communication. And obviously we know some of these tools, and they're very time consuming. So I'm not saying that we need to print out every single one of these, go to each patient and say, okay, fill this out and spend an hour to 2 hours with them talking about this. The concerns obviously are, one, it takes a lot of time, but two, I think there's a lot of concern that patients with end-stage liver disease, you're going to get a pan-positive review of systems. They're going to say yes to everything. They're going to circle a 10 on every single scale, and that doesn't leave you any better off than before, and you have no idea where to start. So my only advice is to really figure out what works for you and try to integrate it into your interviews with the patient as you're talking to them. If it's a patient with PSC, well, you know that they're going to be at high risk for pruritus. You know that they're at high risk for right upper quadrant abdominal pain. Maybe try to focus on that. Maybe they have insomnia from the pruritus at night as well, and those really play a role in their quality of life. One of the best tools I like that I'm going to spend a little bit more time is the best case, worst case scenario. And you'll see that I use this for my patients, both inpatient and outpatient, because it helps provide a packaged kind of plan for the patients. It incorporates disease understanding, prognosis, and the treatment plan as well. So these are just some examples, of course, the Edmonton scale where, there's a bunch of symptoms. The patient can circle on a scale of 0 to 10 how bad that symptom is, or they can also just draw on the picture as well. Of course, it can be time consuming, but sometimes it's necessary. Same thing, distress thermometer gets a very good sense of what's bothering them and is very comprehensive, but once again, the concern is, are patients just going to mark X on every single section? But that does also tell you that, patients with liver disease do deal with a lot of symptoms that we often do not evaluate for properly. And then, of course, trying to dig a little bit more into their mental health, because as we'll talk about, depression and anxiety are very, very prevalent in this population and often undertreated. And then, of course, some kind of assessment for the caregivers. Now, this doesn't mean that every single caregiver that comes in, you need to have an hour-long conversation with them, but we'll often see the signs when the caregivers are not there. They often drop off the patients because the hepatic encephalopathy is too hard to control, but it's still important that we reach out to them, that we call them, and try to figure out what are the barriers at home that are leading to these recurrent admissions. Because, of course, when we try to talk to the patient, they're confused. They're not going to be able to tell you anything. And sure, it's easy enough. Let's give them some lactulose, let's give them some rifaximin, and then they're on their merry way. But soon enough, they'll be right back. So if we don't talk to the caregivers and we don't try to figure out what's causing them to have these recurrent admissions, it's just going to keep on happening over and over again. So one of the tools I like I mentioned, is this best case, worst case scenario. So what is this? It's basically a tool that I write down information and I provide to the patients. It goes through what's the best case, what's the worst case, and of course, what's the most likely scenario. So you don't use medical jargon, you're not throwing in statistics, you're not saying MELD score is this, you have these many days to live, but you can use time ranges. And what you can do is include quality of life measures, something that whatever you've elicited from your conversation with the patients, you include it into this paper, essentially. So this has already been filled out for a patient who has a high MELD who's being evaluated for a liver transplant. This is a very, very common case, obviously, that we've run into. So the best case is, even though the MELD is maybe 15 to 20, maybe they only have to wait a few months. They go through transplant, they recover well, they tolerate their immunosuppression properly, and then they return to their active, usual life. That's the best case. But we should always talk about worst case, because often we see the worst case actually happen. And that's when patients become too sick for transplant. They have to be taken off the list. And then we're talking about comfort-focused care. And it's very important just to even bring it up, because if patients don't know that that's a possibility, it's a huge, huge shock to them. And we've all had that conversation in the ICU when the patients go from the floor to the ICU, and all of a sudden the question is asked, well, we were already talking about transplant, what changes now? And the patient's intubated on 2 pressors, and of course we can't transplant them. They're not going to survive that surgery. But if that's the first time that the patients and their loved ones are hearing about it, that's a huge problem. They're going to have a very, very hard time coming to terms with that. And then, of course, the middle section is probably the most important, is, well, what's the most likely? And you should be very honest, obviously. So I tell people, you're probably going to have to wait several months to get a transplant. And in that time period, you probably will have recurrent admissions for decompensation due to liver disease. You probably will have to get labs very frequently because you're on diuretics. We need to, may be admitted for an AKI. You may have a GI bleed, for example. You may develop liver cancer. So throwing all those things out there is very helpful for the patient so they know exactly what to expect, and so that you're kind of also setting expectations. It makes conversations and consensus later on much, much easier. And so what I want to kind of next talk about, we've kind of gone through some of the tools that I like to use, is well, let's talk about the symptom burden. Let's talk about the different facets of these patients' life in which we can intervene. Because I think the reality is also that we're very concerned. These patients have obviously decreased metabolic function through their liver. They also often have kidney disease as well. So there's a lot of concern about what medications are safe for them and what are not. So we're going to focus mainly on the physical and emotional portions of the quality of life. And so when talking to patients with end-stage liver disease, this is what they often report. Pain, almost everyone has it. Same thing with shortness of breath. A lot of patients have muscle cramps. This is regardless of diuretic use. A lot of patients obviously have sleep disturbance, and this can often be the first sign of hepatic encephalopathy as well. And of course, depression and anxiety is very prevalent, and sexual dysfunction, probably one of the most prevalent symptoms, but yet one of the least talked about and addressed. So I want to first talk about the psychosocial distress. Any chronic illness is going to be a psychological stressor. But in chronic liver disease, we often see episodes of depression and anxiety. The first is whenever they're diagnosed with cirrhosis, there's a huge, huge delay in that understanding and acceptance that cirrhosis is going to be there with them for the rest of their life unless they get a liver transplant. And then, of course, every single time they get a decompensation, it just kind of reinvigorates those same exact symptoms. And eventually, it just becomes chronic depression and anxiety because often a lot of people feel no hope. They feel like there's nowhere but death for them. And it really is an emotional roller coaster, and it impacts relationships, it impacts quality of life, and of course, increases mortality. Over 30% of patients have depression and anxiety in cirrhosis, and it's something that we don't often treat, I think mainly because we're concerned. We don't ask the questions and we don't probe enough, but second thing is we don't we're concerned about the SNRIs, the SSRIs, and what they can do in these patients. And of course, patients with alcohol use, substance abuse, well, they only have one option. They're going to turn right back to that substance abuse if they're trying to self-cope with their depression. And so it's very important when we're seeing patients with alcohol use disorder, figure out, well, why do you drink? Is it because you have untreated depression? Is it because you're bored? Is it some other kind of social stressor? Because it would be unfair to expect them to stop drinking if we're not really helping them treat the underlying cause. And that last line, depression and anxiety can truly be treated safely. And so whenever we're thinking about mental health for patients with end-stage liver disease, there's also a lot of reversible causes. We need to make sure, obviously, they're not vitamin deficient, because that can also mimic a lot of other symptoms. We should be using scales. PHQ-2, easy, 2 questions, and we can figure out a lot about the patients. And SNRIs and SSRIs can be very safe for these patients. Usually maintenance doses are about 50%, and they're very, very effective, and patients are very appreciative of that. So definitely something to consider when you see a patient who seems just very depressed, on the inpatient side. Always open, they're always open to discussing this more. One of the things we don't talk about, especially from the hepatology standpoint, is the transplant distress. As I've kind of alluded to already, we often dangle this idea of transplant as the cure to everything. But in reality, as all of our coordinators know, it doesn't stop there. Patients will still have a lot of symptoms even after transplant. There's survivor guilt, for example. There's a lot of things that show up only after liver transplant. And in reality, not everyone is a candidate for transplant. And so we want to make sure that there's support regardless of what that decision is regarding their transplant candidacy. For patients who are on the wait list, there's this huge anxiety, fear, and depression because their lives are out of their hands. They could very well get more sick, and they could be removed from the transplant wait list. And then what? Is death the only way out? And then even patients who have received the transplant, there's that survivor's guilt I was talking about. There's even concern that the disease could come back. There's the concern for rejection as well, or even just a complicated surgical recovery. A lot of people they have hernias, or they need revision of their ductal anastomosis. They don't have very smooth courses, and some people need multiple redo liver transplantations as well. They also have to get used to a new medication regimen. Of course, a lot of patients love to hear that they no longer have to take lactulose, but of course, then you're still on tacrolimus for the rest of your life. You could get end-stage kidney disease from that as well, and that's a whole different can of worms as well. And of course, throughout all this process, caregivers are a huge support system before, during, and after transplant. That's why you always hear that if a patient doesn't have appropriate caregiver support, they can't be a transplant candidate because so much of their care relies on good caregiver support. And so we often see caregiver depression and burnout increase throughout this process as well. There's also this idea that when patients are removed from the waitlist because their MELD scores improve or they're in remission, well, they end up feeling very frustrated because they're not sick enough to get a transplant, but they're clearly not healthy enough for a normal life either. So they're very stuck in this limbo, and they're left questioning, well, now what? Do we just wait until something bad happens? Essentially, that sometimes is the case, and that's very hard to deal with. And then, of course, the last one where we evaluate someone and they're either never a transplant candidate or they get removed from the transplant list because they're getting worse. And at that point, patients feel very denied. They feel very angry. They feel hopeless as well. So these are things that we rarely talk about, but we need to kind of check in with our patients and ask them if this is what they're feeling, because we do have support for this. We have medications if they have depression and anxiety. We do have interventions, and we do need to provide that support and that discussion with them. So along that same line, the caregivers, I've been kind of mentioning that they're very important. And these caregivers, they don't think of themselves as caregivers. They think of themselves as loved ones. So they often push aside some of that burden that they start to feel because they feel like, well, of course, it's their loved one. They're going to do whatever it takes to get them better. But there are some things that have been actually linked to increased caregiver burden in patients with cirrhosis, and that's listed here. So decreased income, more dependence at home, history of hepatic encephalopathy for the patient, history or active alcohol use in the patient as well, and then more than 2 hospitalizations in a year. All of these increase mortality for the patient and the caregiver, and that's a huge deal. So caregivers need to be educated, obviously, what to look out for, but also need to be educated on taking care of themselves. So if we ever notice that we see that there's certainly caregiver burnout, we need to take a step back and address that as best as we can. And there are a lot of support groups out. There's very specific ones. I just took this picture off Facebook, for example. There are thousands of people in this group for caregivers of patients who have had liver transplants, because life is very different. And sometimes they feel like patients who have not undergone a liver transplant, the caregivers just don't understand. And so there's very, very specific caregiver groups for every single problem that these patients could have. And really what we can do on our end is just provide education. We can make sure that the caregivers have a plan to do something for themselves, make sure that if they need a referral to a social worker or even to their own primary care physician, that we do that. But really we do need to check in with these caregivers. So next, I want to kind of go into some of the other things that we see very, very commonly, both inpatient and outpatient. I'm going to start off with pain. It's very, very common. Now, nociceptive pain specifically is common because patients who have decompensation, whether they have hepatomegaly from alcohol use, they've got ascites from the portal hypertension, there's a lot of nociceptive pain from the splenomegaly, from the ascites, and also from hepatic capsular stretch as well. There's also a lot of inflammatory cytokines that play a role in this as well. So what we need to kind of figure out is what type of pain they have and how we can best help them. So if it's muscle cramps, obviously we're treating that differently than the nerve type pain as well. And a lot of these patients, for example, they have MASH. Well, they also have then long-standing diabetes, and they may have even neuropathy as well. So one of the things, obviously, we all know this in this room, 2 grams of Tylenol per day is the max, but no NSAIDs. And I think a lot of patients often forget that because it's available over the counter. They reach for it, they take it, and then they end up with decompensation or worsening kidney function as well. But one of the important things is a lot of studies have looked at what is the first line, what is a very effective first line treatment for visceral pain, and it's actually acetaminophen and tramadol. And it has worked very well. But of course, we shouldn't just stop there. We can always start with low-dose gabapentin, low-dose pregabalin, and I put that dose there. That's not the max dose that they can handle, but that's what we should start off with. Always start, the theme that you're gonna see what I say is start low and go slow. So gabapentin 300 daily, pregabalin 50 BID. If they start to have, sleepiness, dizziness, well, maybe give it at nighttime, and then hopefully that can help them, with better sleep hygiene as well. Same thing with baclofen or Flexeril. Both are very safe. So if patients are having muscle cramps, sure, we can change the diuretic, we can treat the electrolytes, but why not also give them medications as well? Obviously, starting low is a good idea. So 5 TID is usually a very good place to start. And of course, if they're sleepy, maybe change it to QHS dosing. SNRIs are also very, very, very effective. So it's very good for adjunct pain medications, and I'll go through this a little bit more detail when talking about our program as well and how we use this. But duloxetine, amitriptyline, nortriptyline are very, very helpful. We just have to be careful about the anticholinergic side effects. Of course, everyone already is making sure that these patients are not encephalopathic, but of course, very high doses of pain medications can precipitate encephalopathy. So although opioids are very, very effective because of an increased therapeutic effect, we just have to be very cautious about them. The other big thing is a lot of these patients have what we call reversible causes, so they have a lot of ascites. There's a lot of concern with how we treat ascites. LVPs are great. Large volume paracentesis, we should say, hey, just get this once a week, maybe even a couple times a week. But we have to remember that patients need a ride. Patients need to be able to be close enough to a center that can do that. Some patients have low platelets and they bleed every single time. There's a couple of patients that I have who have their platelets in the single digit. Every single time that they undergo a paracentesis, they end up with a hematoma. And then that doesn't help anything because then they end up just filling right back up. So in those cases, I think it's very important that peritoneal drains are not really just reserved for hospice care. Of course, we're very, very, very cautious when we put it in a tank-off tube because there are a lot of complications from that. But just because they haven't been studied in patients that are not end stage of their life doesn't mean that we can't use them. We certainly have patients who have had peritoneal drains that are not end of life, and they do just fine. Of course, if they develop SBP, or in this case, secondary bacterial peritonitis, sure, we can just remove the tube. We can either sometimes even treat through it. But there are patients who just cannot tolerate serial paracentesis, and they just need to be at home and draining it themselves. But obviously, there's a lot of things that we need to educate them on and their caregivers. So if they don't really have a good caregiver plan, then maybe that's not the right move for them as well. And TIPS in itself has its own contraindications. We don't want to put a TIPS in someone who has a high MELD because we're just going to precipitate liver failure. We don't want to put TIPS in someone who has recurrent hepatic encephalopathy because they're just going to end up right back in the hospital as well. So all these things really do need to be considered, but I think it needs to be a very patient-centered approach, and that is something we definitely do on the inpatient side as part of our inpatient program. One of the things that is potentially a cool new treatment is an alpha pump. Now, we don't do these here to my knowledge, but as of January of this year, they are available in the United States. I'm not exactly sure who's doing them, but the idea is that it's a subcutaneous pump where the fluid goes from the peritoneal cavity directly into the bladder. Now, of course, you can probably already see where the issue lies here. Is sure, there can be issues with the pump themselves, and of course, if patients are already having incontinence, they're already complaining, hey, when I take my diuretics, I'm up all night peeing. Well, I'm pretty sure this is gonna make this worse. So obviously, if this ever becomes a thing, probably don't choose the patients who already have incontinence or issues with spending all day in the bathroom. The next thing that's huge that we often deal with is nausea and vomiting. Whether this is because there's a bunch of ascites in the abdomen pushing on the stomach, whether it's because we're doing it to them because lactulose, it's non-absorbable. It causes a lot of gas bloat. There's a lot of causes for nausea and vomiting in this patient population. And we shouldn't just ignore it and say, okay, take some Zofran and you're on your way, see you later. We kind of get stuck into this idea that every single patient with cirrhosis needs lactulose. Well, it's not really lactulose that treats the encephalopathy, it's the bowel movements. So you'll often see when patients are complaining that they're very distended, but they don't have a lot of ascites, well, it's probably the lactulose. How can we expect patients to gain weight, gain muscle mass, increase their PO intake when they have a bunch of gas from the lactulose we're giving? So using, Miralax instead of lactulose, or, lowering the dose of lactulose is very helpful, or just doing whatever it takes to get the 3 to 5 bowel movements. That could vary from patient to patient. But that's something we should not forget. Ginger, I've seen, has also worked pretty well in this population. Obviously, I don't think we can order ginger from the Barnes cafeteria and have the patients take it, but it's a thought for, at home, something to try, because a lot of patients are looking for ways to decrease their pill burden, and ginger could be an easy way of doing that. What I personally like, and you've probably seen this in a lot of these inpatients that I've seen as part of the program, is low-dose Zyprexa standing at nighttime. So 2.5 milligrams, because not only does it help their insomnia, but it usually provides at least 24 hours of antiemetic care as well. On top of that, you can either schedule something or do it PRN. Compazine often works better with Zyprexa compared to Zofran, but either is fine. Whatever works for the patient. Obviously with Zofran, you obviously want to be careful that you're not precipitating constipation, and then of course making the encephalopathy worse as well. And of course, if you're using Reglan, there are studies that show it's safe, but maybe you should probably reduce that by 50%. But otherwise, it is very effective as well. And of course, you can use Haldol if needed, just usually in the short term. So there are a lot of options, and I think we should kind of get away with just treating the symptom and just making sure that it's not something else that we need to work on. If it's refractory ascites, maybe we need to work on that a little bit more to help them with their nausea and vomiting. And then the next is the shortness of breath. A lot of patients also have this as well. And I have a picture here kind of describing one of the most common causes of shortness of breath in our decompensated cirrhotics, and it's hepatic hydrothorax. The tough thing with these hydrothoraces is that they don't respond to diuretics. They definitely don't respond to IV diuretics because they function very differently than pulmonary edema, which also means most of these patients are not hypoxic. So it's not as easy to just give them supplemental O2. They usually don't get it approved by their insurances because when they do the O2 test, well, they don't fail it. And so it's very, very hard to get this fluid out. And even if the cause is due to portal hypertension and ascites that's getting sucked into that pleural space, for some reason, even if we do, serial paracentesis, even if we put in a TIPS, sometimes that's not enough. Even diuretics is not enough. So at that point, I think we need to have more discussions about putting in Pleurex tubes. Of course, as long as we educate the patients and caregivers about the risks, Pleurex tubes can be very, very useful and can improve quality of life significantly. Because many times, especially at end of life for these patients, they're describing this shortness of breath, this inability that they can't breathe. And that is very difficult to see them suffering through that. One of the other things that I really, really like, and I've been successful in getting this for some patients here, is bedside fans. Because they can't get, supplemental O2 all the time, just putting a bedside fan and just having it blowing on their face significantly helps them with this symptom of shortness of breath. And it's simple, right? It's just a fan. And of course, if they end up going down the end-of-life comfort route, obviously hospice can have access to more liberalized use of oxygen, but that doesn't always apply to these patients. The other thing is muscle cramps that these patients commonly complain about. And this could be due to diuretic use, because obviously there's a shift in volume, there's change in electrolytes, but it also just happens in decompensated cirrhotics as well. The etiology is not as clear, but it probably has something to do with alterations in the nerve function. So I have a beautiful picture here of a glass of pickle juice, and it's phenomenal how well this works. But just educate them. I have a patient who was chugging pickle juice at home. She sends me a message and says, "It's great, my muscle cramps are gone, but now I have a bunch of swelling." Yeah, there's a lot of salt content in pickle juice. So obviously it just goes to communication and education, but it works very, very well, and patients don't have to take more and more medication. The other treatment I bolded there is quinine. So tonic water, obviously I tell patients, leave the gin out. Tonic water, is very, very helpful too. The quinine is very, very beneficial in helping muscle cramps. In Europe, they use a lot more taurine and branched-chain amino acids. So obviously here, we don't tell people to go pick up some Monsters or some energy drink that has a bunch of taurine, but it has been shown to help. And of course, we want to make sure that we're checking electrolytes, adjusting diuretics as needed, just making sure we're checking the reversible causes as well. And of course, as I mentioned before, muscle relaxants are safe. We can do baclofen, we can do Flexeril, we can't even do Robaxin, for example. The other thing that we always commonly deal with is pruritus. And I show this picture because this is hot chocolate that's not mixed very well. I show this picture because we often reach for cholestyramine as our first treatment of pruritus. And this is because usually pruritus in cholestatic liver disease is due to bile acids that are building up, and then it's irritating the nerves, and it's causing them to itch, itch, and itch. So of course, why not start with a bile acid resin, something that's actually going to bind these bile acids and then get rid of it? Well, this is why we don't always start with it, is because cholestyramine is an extremely gritty powder. Just imagine having to drink this 2-3 times a day, otherwise, and obviously then you have no other way of getting appropriate symptom control. So of course, no one actually adheres to this regimen. They end up saying it didn't work, but in reality, it's probably because they didn't try it enough, but to no fault of their own, it's absolutely disgusting. Of course, there's a pill version of it called Colestipol. Some people say it's not as effective, but also insurances don't always pay for it as well. So we always have to think outside the box a little bit. And there are other medications for pruritus as well that we shouldn't forget about. So there's sertraline, for example, can kill 2 birds with 1 stone. There's naltrexone, really works well for people with alcohol cravings and pruritus. Then of course there's rifampicin as well, which we just have to be careful with in patients with decompensated cirrhosis. But on top of that, antihistamines work beautifully. So they help with sleep at night. So patients who are having issues with insomnia, both Benadryl and hydroxyzine are very, very effective. But the important thing is we just have to check in with the patients, figure out, well, why aren't these medications working, and can we add something else? And that leads me to something we very, very commonly see is all these sleep disturbances and hepatic encephalopathy. One of the first signs of hepatic encephalopathy is actually a reversal of their sleep-wake cycle. So that's something that everyone in this room can ask when they see a patient come in, is even if they don't seem overtly encephalopathic, you can ask a simple question of their sleep at night and see how they're doing during the day. If they're having a very hard time getting up in the morning and staying awake, that's probably covert hepatic encephalopathy, and they probably need treatment. And a lot of studies have tried to look into why this is, and there's a lot of changes in cirrhosis where the metabolism melatonin changes, at nighttime the thermal regulation is disrupted, so our bodies are a lot warmer, and that all disturbs the circadian rhythm. So the goal is, of course, trying to reintroduce a normal rhythm again. Now, one of the things that I've alluded to in the past is lactulose is it's a knee-jerk response. Okay, encephalopathy, give lactulose. But just be careful about that gas blow, and just be careful about giving too much. We don't need to have these patients spending all day in the bathroom having 10, 20 bowel movements. That actually can precipitate encephalopathy. That can cause renal dysfunction as well from dehydration. And of course, then patients are just going to stop taking it. So make sure that you're discussing with these patients if they're taking it and making sure that they know what the goals are. And of course, rifaximin, it's great, but does it really make a huge difference? Do we need to have patients pay $2,000 a month when they can't really afford it, when really it's probably not going to change a lot for them? So one of the things that I often see is a patient we know cannot afford rifaximin, but when they come into the hospital, we start rifaximin. Well, is that really fair to them, where we're starting rifaximin, and then when they get discharged, we stop it? Something to think about, that maybe that rifaximin is not needed. Of course, the zinc repletion has been shown in a few studies to also to help with hepatic encephalopathy. And then there's the idea of L-ornithine aspartate. That is basically a substrate in the urea cycle. So I put a picture here, flashbacks to medical school, I'm sure, but basically it's a substrate in the urea cycle, so it helps get rid of the ammonia. The issue with that, once again, is patients have to buy that themselves. It's $100 a bottle. They have to buy it online. They can bring it in. We can administer it, but that's a huge, huge barrier to getting this. So is it reasonable to expect that every patient is going to be able to afford and get this? Probably not. But what can we do then? Is we can make sure that they're getting good sleep. So, good sleep hygiene, both here in the hospital and at home. Melatonin works well, but of course we all try it and it doesn't work. Zolpidem works very well as well, and of course making sure that we're not precipitating in hepatic encephalopathy is very important. But as I mentioned, Benadryl and hydroxyzine are also very, very, very effective. And the other thing that we tell people is make sure that if you need to take naps, take a nap throughout the day, because there are as I talk about fatigue in the next slide, it's very important that we make sure that they understand that if they're tired, they shouldn't overdo it, because that's also when problems arise. So talking about fatigue, it's very, very difficult to treat in patients with end-stage liver disease. And there's two types. There's central fatigue and peripheral fatigue. So patients with cirrhosis have both, but what we often see is the peripheral fatigue, where we see this neuromuscular dysfunction and then a lot of muscle wasting, a lot of frailty and fatigue and weakness. Of course, if these patients have nausea, vomiting, how can we expect them to chug 4 Ensures a day? So we need to make sure that we're making sure that they're tolerating everything, that we're fixing what is reversible. And then, of course, we can start talking about what are some pharmacological therapies. Modafinil can be used safely in cirrhosis. Obviously, we need to be monitoring them, making sure that we're not making their insomnia worse, making sure we're not making their other symptoms worse. But if you dose reduce by 50% in the beginning, most patients can actually tolerate that. Methylphenidate hasn't been studied as much, but it can be used still in cirrhosis, and there are a lot of people who have successfully used it. And then the last symptom that I wanted to talk about that is often the least talked about is the sexual dysfunction. In any patient with cirrhosis, there's a hormonal imbalance. That's why we see the palmar erythema, that's why we see the telangiectasias on patients with chronic liver disease, because the estrogen is not being metabolized, there's low testosterone as well, and it's just very difficult to organically bring up these symptoms and ask for this. So very rarely does it ever get brought up and treated, but it can be treated safely. We also need to make sure, like I mentioned, we put everyone on CoReg these days for primary and secondary variceal bleeding prophylaxis. Well, it can cause sexual dysfunction. So did the sexual dysfunction start after CoReg? Well, then we have to address that. Maybe we need a different option. But also, phosphodiesterase inhibitors have been safely used. There's studies behind them. And there are also actually treatments for complications from portal hypertension, like portal pulmonary syndrome. So we can use them. And of course, just make sure you're not giving them to patients who have a systolic blood pressure in the 70s or 80s, because obviously that's not going to go well. So that's really what I wanted to talk about, just a kind of a brief overview of how I like to look at these symptoms and how I like to kind of elicit some of these unmet needs. And that I want to transition, for the last few minutes to talk about this inpatient program that is brand new here. And I do want to give a special shout out to Dr. Dan Paget from Palliative Care, who really helped bring this program to fruition and really helped get these patients the care that they need. So what we started with was a needs assessment, and this started, last year in April to August. We enrolled 50 patients. We gathered a bunch of data. We asked a bunch of questions. We kind of knew what we were going to expect, that there's going to be a huge unmet need in this population, but we wanted to figure out what was that need. We wanted to quantify it a little bit better. 2 of the scales that we used are things that I think are very, very important in palliative care. It's the heard and understood scale, and it's a caregiver assessment. And the heard and understood scale is exactly what it sounds like. 4 questions asking the patient, well, how much do you understand about your care, the treatment, the prognosis, and how much do you feel like your team, whether the hepatology team or the internal medicine team, is actually taking your preferences into account when coming up with a treatment plan? And of course, the caregiver assessment that we used is an adaptation from the American Geriatric Society. So instead of asking 12 questions, we asked 4 questions about how they're sleeping at night, what their mood is like, if they feel hopeless about the future, or if they feel any hope at all. And so just to kind of briefly summarize this, a majority of these 50 patients in the need assessment were Caucasian males with alcohol-related liver disease, and the median MELD was 26, and most of them had multiple readmissions over the past 6 months. And so a majority of patients did not feel heard or understood. They had no idea what their diagnosis was. They had no idea what their treatment options were. They really did not know what their prognosis were either, and they really felt like there was a delay in understanding. Obviously, some of this we can't really change because some of these patients come from 3-4 hours away. They've been living, in rural Missouri for years and years with cirrhosis, and then something happens, and then they come to us, and that's too late at that point. The whole point of this program is to intervene early and to talk about this early so that we communicate illness understanding and disease expectations as well. So a lot of people also said, yeah, sure, I know what a code status is, but no one really went through what my true goals of care are, what really matters to me, and how that affects my treatment plan. And when we asked the caregivers how they felt depressed, and they felt very hopeless about the future, and they were getting very restless sleep as well. So what do we take from this? As we kind of figured, there's a huge unmet need. There's a very big disconnect between patients and providers, and a lot of this just stems from a lack of understanding and discussion regarding the diagnosis, the management, the prognosis for these patients. And of course, the higher the MELD score, the more the symptom burden as well. And there was definitely signs of caregiver burnout as well, and patients just felt like care was just given very late in their disease course. So this led from the needs assessment to our pilot. So the pilot took place from November 1st, 2024 to May 1st of this year. We ended up enrolling 35 patients, and this basically in the red just highlights how we try to address this unmet need. We really try to build that relationship between patients and providers. We really try to address this disparity in understanding of their knowledge. So what I did was I did the best case, worst case scenario, which each patient, I took time to talk about their diagnosis, their prognosis, and what the treatment plan was. And of course, we included patients with high MELD and high symptom burdens who had a lot of recurrent admissions as well. And of course, we involved the caregivers when we could. So we usually, these were tandem visits, so it was myself and a member of the palliative care team, usually Dr. Paget. We usually spend about an hour with these patients going through everything we just talked about in this presentation, talking about all the symptoms, going through these surveys, and figuring out how we can help them. We made these changes, we talked to the primary teams, we talked to the inpatient hepatology teams, and then we followed them along as needed, and we basically gave them surveys along the way. Once again, majority Caucasian males with alcohol-related liver disease, median MELD of 29, and multiple readmissions. So instead of showing you every single data point, I'm just going to show you what the changes were in these surveys after the interventions we made. These interventions could have been pain medications, could have been working on nausea, vomiting, working on their insomnia. Essentially what you see is there's improvement throughout all the factors on the scale, but the most were actually the pain and nausea and overall well-being and appetite. And I will say that probably only one of these 35 patients ended up getting opioids as their pain regimen. The rest were done with just adjunct pain medication. So that could have been gabapentin, pregabalin, muscle relaxant, any of those. And so it is very doable. And of course, this was a pilot, so it was a short period of time. So of course, it is going to be very interesting to see how they do long term. And then with the heard and understood scale, I kind of like these results even more, is majority felt that they were actually heard and understood, almost 100%. They finally understood their diagnosis. They knew what their prognosis was. They knew what their treatment plans were as well. Even if that meant that transplant was not on the table, they still appreciated knowing that information as well. And everything was outlined. So whenever we met with these patients, we made sure that there was documentation so all teams knew what the plan was and what the discussion was. And even the caregivers had some improvement. They felt a little bit more hope about the future. They were able to get a little bit more sleep as well. And the outcomes really ranged across the table. So some patients who are ambivalent about transplant, they said, well, after discussing this and understanding what my diagnosis is, what transplant is, they wanted to proceed. And of course, some people said, well, I want the exact opposite. I don't think transplant is for me, so they were actually removed from the wait list. Some people completely avoided transplant evaluation once they realized that it wasn't what they thought it was. And then, of course, some people we transitioned to comfort and hospice care, and some we just talked about their symptoms, talked about their illness understanding, and just provided support to the patients and the caregivers as well. Overall, it really did improve the quality of life and the patient satisfaction. Of course, it also improved with earlier and easier consensus of care at the end of life. There were a lot of patients who, when they went to the ICU, we had already had these discussions. So we knew that they were not going to be coded for the hour. They were not going to be kept on a ventilator for weeks and weeks. They were not going to get a trach. They knew that that was not part of their plan and goal of care. And so that was just avoided altogether. And they were able to go home and live the rest of their life at home with their family instead of passing away in the ICU with people they don't know. One of the things I do want to point out is the MELD score, it won't improve with this program, and that's not the point of this program. This is really focused on quality of life and patient satisfaction. I expect the MELD to get worse, if anything, because like I mentioned, this is a progressive disease. But one of the things that I like the most about this, and I think I got a lot of great feedback from the internal medicine teams and the hepatology teams, is that we finally had a patient-centered, cohesive plan of care. There was no question about, is this patient a transplant candidate or not? What's the next steps? What do we do about these symptoms? There was no need to keep on calling the hepatology team back because the patient had more questions. Everything was addressed, and we left information with the patient and their family so they knew exactly what to refer to. And this, of course, leads to the program, which is currently active right now. What I currently do is I see patients by myself. I choose patients from the inpatient hepatology list, patients with high MELD scores, high symptom burden, recurrent admissions. I reach out to the inpatient team, the hepatology team. I make sure it's fine with the patient. As long as everyone's okay with it, I go see these patients. I talk to them about all of this. Usually it's about an hour long. I see these patients throughout the week on an as-needed basis after that initial visit, and I help with this quality of life. I talk about the best case, worst case scenario. I leave information with them that they can refer to. I leave my information as well, so if there are any questions, they know who to reach out to for symptom management. I document this as well with an advanced care planning note so everyone's aware of what we discussed, and so that if the patient does go to the ICU, then we kind of have something to refer to that's already been discussed in depth. And of course, caregivers are always involved, whether in person or on the phone, and I easily can adjust when I see these patients based on the caregiver availability as well. And of course, this is an ongoing collaboration with palliative care. So let's say, for example, we do need a little bit more expertise, or let's say we do need transition to hospice or comfort care. I would always provide that handoff tool to the hospice team because I'm the one having that conversation. So it would only make sense for me to let them know what we talked about and what's appropriate for that patient. Of course, if the patient is interested in spiritual care, I can help arrange that as well. So there's a lot of different aspects that I try to intervene upon here. So if there are any patients that you guys can think of, please feel free to email me, reach out on Epic, send me a message. I'm always happy to see these patients throughout the week. And hopefully as this program takes off, maybe this can also be an outpatient clinic as well, especially for our transplant patients where someone sees them for symptom management at the same time of being evaluated for transplant so that if they're not a candidate or even if they are, there's someone that's always talking about their symptoms as well. And so with that is all I have for you guys. I want to say thank you guys once again. I want to say special thank you to Dr. Davidson, the entire division of GI and hepatology for supporting me through this. Of course, Dr. Paget as well for helping me get this program into reality and help the patients get the help that they need. So thank you guys very much.
Parth, thank you so much. That was really terrific. What a great program and great new vistas of hope for patients with end-stage liver disease. So can I just ask you, for the patients who've decided they want to come off the list, is that decision irrevocable or are they allowed to change? And what is the pathway for communicating that?
It's a good question. So usually we try to only make that decision once. Now, of course, that decision can always be reversed in the future as well. Some patients decide that they're not at the right time in their lives, whether it's because they have to care for a family member who's very sick, and so they want to be temporarily taken off the list. So in those cases, it can be reversible. But in this case, when we're talking about palliative care and whether or not it's truly part of their goals of care to even get a transplant, usually those discussions are a lot more irreversible, because I think if we were to consider reversing it, I think that just adds a lot more confusion to those patients. And so most of my conversations in which the outcome has been remove the patients from the transplant, those are usually permanent.
Yeah. Dr. Fraser.
That was a really terrific talk. Thank you so much. It seems like a tremendous opportunity for it to be available to many more patients. But how to figure out your time and effort and make it more sustainable to a larger group of patients. Do you see what are the options for other methods to deliver this level of education and communication, beyond you seeing every single patient yourself?
Yeah.
Can you just reiterate the question?
Yeah, so great question. It's really how can we make this sustainable, because right now this program is just me, and how can we get, we have so many patients with end-stage liver disease that need this attention and care, and so how can we get it to a broader group of people? And one of the things that we've thought about is, of course, this is an ongoing collaboration with palliative care. There's also a potential strong role for APPs to be a part of this as well. There's a lot of programs, palliative care driven programs, not necessarily hepatology driven, that do a lot of televisits and telephone calls where they're kind of checking in with these patients and talking about these symptoms, and then having visits, maybe once a month in that regards. And that can potentially increase that outreach, especially for these patients that are coming from 3-4 hours away and can't always make it to our clinic visits here. But the hope is also, palliative care is more effectively given in the outpatient setting. It's early, and it's before the patients are, life and death situations, and they can actually make that decision for themselves. And so the other next step potentially is being able to involve palliative care and maybe have an outpatient clinic so that we can bring in more of those patients before they come into the hospital. And I know there's a lot of also fellows that are interested as well, GI fellows, and so being able to bring them on board, even palliative care, residence fellows, and just expanding the knowledge base in that regards.
Great, thank you, Parth. All right, take care, everybody. Thanks for coming.